Hello, I'm Catherine Dixon-Hurt. I'm the EMS for Children Project Director for the Alabama Department of Public Health Office of EMS. The purpose of this program is to update EMS personnel on the changes to the Alabama patient care protocols. These protocols were updated in 2015 and went into effect on January 1, 2016. There have been a number of questions raised, and today we hope to help answer some of those questions and aid in the training. Joining me today are Dr. Shay During, Pediatric Emergency Medicine Fellow with Children's of Alabama, Dr. Ann Klasner, Director of Pediatric Emergency Medicine Fellowship Program at Children's of Alabama, and Dr. Sarah Nafziger, Assistant State EMS Medical Director. Welcome. Now we'll get started.
First of all, we have nothing to disclose. We are not getting any compensation for any of the products that we do discuss today. The objectives, as Catherine mentioned, we're going to talk about a lot of the new updates that have been instituted in the 8th edition protocols. We're going to talk about some new drug delivery systems that are available and discuss some of the science and literature behind why these updates happened. So we'll go ahead and get started. First, we want to start by talking about intranasal medications, which has been a great advance here.
Absolutely.
A lot of changes here.
So intranasal medication has been around a long time. It first was brought forward by just local use for intranasal medication only. But then it expanded to more systemic use. Started with, for example, intranasal immunizations. For example, flu mist we have seen in the past. It's been expanded into a number of other areas. Seizure control, pain control with fentanyl usage, Naloxone most recently. And there are a lot of other places it's seen. But the three primary places we're using it here and for pre-hospital are going to be for seizure control, Naloxone, which is a new and innovative change that we are seeing this year, and Sarah's going to talk about in just a minute, and then for pain control with fentanyl use. That's been long-standing, but we want to highlight that's still available, and you should consider that if you need pain control. Why intranasal medication? It's a great route. The local effect is easy. The nose is highly vascular. They're in the nasal mucosa. There's a wide area of the absorption. It allows for avoidance of IV placement, which, especially in the pediatric population, can be a great advantage that we have. And patients have high tolerance of it. There are two different ways that you can use intranasal medication. You can use a drip method, where you would literally just drip the medication into the nose. Not well tolerated, not very comfortable, but it is a usable form. The other way that you can do it is by atomizers. And the EMSC program has been lucky enough to provide these for all agencies. These are small devices that insert on the end of syringes and easily atomize the medication into the nose. You should use the smallest volume you have available. Don't dilute the medication with anything else. You should place it in the nose, easily flush it in, half in each nares. It's very quick when you do it in this fashion and usable. So these have been distributed to all of the agencies. You should check with your medical directors about getting these for your rigs and starting to institute the use of them. So this is a perfect time, now that we've mentioned the atomizers, to kind of segue into talking about some of the places where we're seeing intranasal use. And the first one will be Naloxone. This is, I think, a great opportunity. Sarah, tell us about why we're doing Naloxone.
Sure. So anybody who is working in EMS now is very much aware that we have seen an explosion in opiate overdoses over the last few years, and unfortunately a lot of deaths related to that. So really what we wanted to do is try to address that from the public health perspective and make Naloxone more widely available. So we looked at the problem and thought about what we could do to fix that, and we decided that we could expand Naloxone down to the EMT level scope of practice. And when we looked at that, we decided that intranasal was really the best method to do that for the EMTs, since they are not really allowed to start IVs. So we decided that intranasal would be the quickest, most effective method for that. Intranasal naloxone works very quickly, a lot more quickly than intramuscular naloxone, and that's why we selected intranasal over intramuscular. I've had a lot of people ask me that question, actually. So what we're going to do is make intranasal naloxone. It's now a mandatory drug for BLS transport agencies. We're also going to allow EMTs to assist the patient with their own naloxone if the patient has it, because what we're seeing is actually some physicians have prescribed naloxone for the patient and they may have it at home. And you can encounter this as auto-injectors similar to the EpiPens that we've seen in the past. It can be sublingual or maybe an intranasal delivery method. So we're going to allow the EMTs to assist the patient if they have their own as well. So that's an innovative new way that we're using intranasal drugs. Now, we already had intranasal naloxone available for the advanced EMT and the paramedic level, and that's still available to them. And the advanced EMT and the paramedic can also still give naloxone intravenously or IV. That's fine. But this intranasal methodology is also fine for the advanced EMT or the paramedic and may very well be preferable if time is of the essence and they don't have IV available. The dose is going to be 2 milligrams intranasally with a maximum of 8 milligrams. And this is a point that I think is very much worth mentioning, is that you can titrate the dose of naloxone. The whole point, when you give a patient naloxone, the whole point is to wake them up enough so that they can protect their airway and have spontaneous respirations. But you don't necessarily want to induce that acute opiate withdrawal that results in sometimes a patient being confused and combative. So it's perfectly fine to titrate to affect an adult patient in particular. Now, naloxone can also be used in the pediatric patient. Ann, would you like to talk about that?
Sure, absolutely. Since they have expanded the scope for intranasal medications, we felt it worthwhile to go ahead and talk about this in pediatrics as well. And for convenience and ease, it's great that the dosing for pediatrics is actually 2 milligrams as well, intranasal. And it's standard dosing no matter the size, the age, the weight of the patient. In pediatrics, 2 milligrams intranasal is the dose to be used. Like adults, you could titrate if you so chose, but in general, it would be rare that a pediatric patient might face an opiate chronic abuse situation. So the recommendation is in pediatrics is to stay with 2 milligrams primary dose all of the time. I've gone ahead and also listed the doses for IV, which remain as well. The 0.1 milligrams per kilo if you are less than 5 or less than 20 kilos, up to a max of 2 milligrams. And then if you're greater than 5 or greater than 20 kilos, to give 2 milligrams IV. So just so that those doses are out there and you know what they are.
Awesome.
So another place I know that we made some big changes, which are really exciting, were with intranasal medications and seizures. Shay, you want to talk about that?
So the seizure protocol was updated this year, and most of it, the changes really affect pediatric patients. Due to drug shortages, we'd added multiple different drugs to the protocol over time, and so with a bunch of different dosing ranges, and it got a little confusing. You had like 3 different drug dose ranges to remember, which kind of sets up for sort of some patient safety errors. And so we simplified the dosing of all the medications on the protocol for IV dosing down to 0.1 mg per kg, and in order to make this a little easier to use and easier to remember. We also, again, as Ann mentioned, added intranasal medications this year for seizure control as well, which is great for providers because now they don't have to try and put IV lines into kids. IV access in kids is hard, especially when they're seizing and you're bouncing down the road at 70 miles per hour. So now we've added intranasal midazolam for route of seizure control in kids, and we've kind of marked it now in the protocol as the primary method because it's really just for ease of administration. It's been shown to be very successful in head-to-head trials with IV IV Valium is shown to have the exact same rate of seizure control and a lot easier administration. And even when compared to rectal Valium, which is still in the protocol as an option, it's actually easier to administer and actually has a better rate of seizure control with less sedation after seizure control. So intranasal midazolam is definitely sort of where things are moving for pediatric patients and in the absence of IV access. The dose is going to be 0.2 mg per kg with a maximum dose of 5 milligrams. And again, as you can see on the protocol here, it's sort of been flagged as the preferred method of seizure control for kids. And again, that's where those atomizers that Ann was mentioning earlier that EMSC has distributed are going to come in really handy. Again, as she said, though, you can drip the medication directly in the nose, but atomizers really make for better administration, a lot easier, a lot lot better absorption. We did retain IM midazolam for adults as a route of administration if you can't get IV access. Intranasal midazolam was not added for adults there because, as you kind of pointed out during the protocol meetings, the data just isn't there for adults yet.
That's right. That's right. That's something we might see in the future, though. But right now, the data's not there to support intranasal midazolam for adults.
Right. And due to the sedating side effects of these medications, remember that all kids after administration should be monitored, and adults should be monitored very closely for any sort of respiratory compromise or airway compromise. And that'll sort of segue into spinal injuries.
Awesome. So spinal injury is a topic that if you look in any of the EMS journals, the professional journals, any of the commentaries out there, this is a hot topic right now in EMS. People are really questioning the use of spine boards and talking a lot about how spine boards can actually cause injury in the patient, not only because of aspiration risk and respiratory compromise, but because of actual pressure sores that develop very quickly in patients who are mobilized on spine boards. So really what we wanted to do is de-emphasize the use of the hard backboard on these patients and really take a close look at what our protocols say. So if you look in our protocols, we already had some outs, if you will, from some excuses to get you out of having to immobilize a patient on a long spine board. But we wanted to go a step further and define something called spinal precautions rather than spinal motion restriction, which is what we've always used. So spinal precautions is a new thing that we've added, which basically amounts to a cervical collar and the EMS stretcher rather than a backboard. And we wanted to define that as another method for providing some motion restriction without a full backboard and full immobilization. Another thing that we talked about is really trying to limit the amount of time the patient's on a hard backboard when one is needed, because there are certainly times when the literature still supports the use of full spinal motion restriction, particularly in our severely traumatized patients. So we just kind of changed some language to talk about there may be times when maybe you can remove the backboard from the patient during your transport. So, for example, if you have a really long transport, you might be able to put your patient on your EMS stretcher on the backboard, remove the backboard for the transport, and then put them back on the backboard when you get to the hospital for those really long transport times. So we're really trying to evolve this protocol to match the status of the current scientific literature and limit those times that the patient is strapped down to a hard backboard, but also still maintain safety for the patients who may have a serious spinal injury.
Excellent. I think, too, some of the pre-hospital personnel may encounter a little bit of pushback as they come to bring these patients in. This will also be a change for the nurses and the personnel at the hospital, and I encourage them to probably just let them know this is a protocol change, and in case the nurses or the staff at a hospital were to give them any.
Absolutely. I commonly hear those complaints from EMS providers. One final note on that is that we updated the algorithm and the protocols on that. And also one little notation we added is that you really don't have to do spinal motion restriction for penetrating trauma unless you suspect spinal injury. So we're really trying to help the EMS providers get away from using spinal motion restriction when they don't have to. All right, the next topic is CPAP, and CPAP is something that when it first came on the scene a few years ago in the EMS world, I truthfully at first was not all that excited about it, but boy was I wrong. CPAP has really made just an amazing difference in adult patients in the EMS setting. We have really when I look at EMS advances over the last 10 years, I think this has probably impacted patient care more than anything that we've done or added for adult patients. So when we started revising the protocols this time, the question came up, well, since CPAP has been so useful, should we expand it down to the EMT level scope of practice? And so what we did was the committee pulled the literature and reviewed the literature and found that sure enough, people have studied this and found that at the EMT level, CPAP has been used safely and effectively. And so we decided, based on that evidence, to expand our scope of practice for CPAP down to the EMT level. The other thing we did is we added BiPAP as an option for services that want to use BiPAP if their service medical director approves it. So CPAP has been added as mandatory equipment for BLS transport agencies by June 1st, 2016. Another reason for that decision was because the cost has come down significantly from when these things came on the market. So CPAP is something that we're really excited to see growing, and we're excited to see its use expanding. Now, let's talk about which patients you can use CPAP for. It's really for patients who have respiratory distress, who are awake and comfortable enough where they can cooperate with it. Patients who are altered and can't cooperate very well with you really can't use CPAP well, but definitely patients with respiratory distress can. What about CPAP in peds?
Well, not indicated yet. Not in the pre-hospital setting anyway. Yes, CPAP is used on occasion in the pediatric population, but that's limited to hospital use and some very controlled studies. So in the pre-hospital setting, we are not using it in the pediatrics.
Awesome.
Dextrose. This is another topic that warrants us talking a little bit about. Dextrose is used for hypoglycemia, and hypoglycemia can show up in a number of different situations, including diabetes, malnutrition, alcohol abuse, poisoning. Specifically in the pediatric population, we see it a lot with sulfonylureas. This would be a small child who gets into grandma's diabetic medication, and that can be very deleterious to a child. Or a child or a patient who has altered mental status might have hypoglycemia. In most cases, not all cases, it doesn't specifically matter why a patient is hypoglycemic. Now, if you believe they're hypoglycemic because they are malnourished or they have alcohol abuse, then thiamine must be given prior to dextrose. But in the remainder of the cases, it's not the pre-hospital's job to sort out why a patient is hypoglycemic, rather to recognize they're hypoglycemic. The problem is that D50, which was what was standardly recommended in the protocols, has been very difficult to get. And so we looked at this, reevaluated it, and felt like we should have some alternatives out there. So now in the protocols, we've added D25 and D10 as other options for ways to give dextrose in hypoglycemic patients. So consult with your medical director, find out what you guys will be carrying locally, and then make sure that you have your dosing appropriate for that.
And really, D25 and D10 are preferred for kids. It saves you having to dilute D50, which makes it kind of nice.
Actually, you make a great point. And D10 is far less sclerotic on veins, and so really much safer medication to use.
Awesome. Well, now we're going to talk about our old friend amiodarone. Amiodarone is been around for a while. It's not a new drug to the protocols, but one question that we get at the state EMS office a lot is questions about dilution of amiodarone, because it's mentioned in the AHA protocols to dilute the amiodarone, and there are some studies that indicate amiodarone, when you push it, that it can cause hypotension and bradycardia, actually. So the protocol committee researched this topic and looked at the different ways that you can mix amiodarone, and it turns out there were a lot of choices. So they pretty much kind of had to narrow it down to something that we could all agree on would be easy to do in the EMS setting. And so we put those recommendations into the protocols. One thing we talked about is we really, in patients who are pulseless or, for VFib or pulseless VTAC, we wanted to make sure that dilution of amiodarone did not delay treatment. So the committee really felt like their recommendation is that the amiodarone may be diluted in those settings, but it is not made it a requirement, because we understand that in certain circumstances, a paramedic may be working alone. They really may not be able to dilute it in that setting. So we felt that the time spent diluting the medication was just not worth the risk of maybe them not being able to do chest compressions for that time period. So the recommendation of the committee is that it'd be nice if you can in that circumstance, but you don't have to. However, they did recommend that you dilute the amiodarone in patients who have a pulse. So that's really the summary of the changes in amiodarone.
Interesting.
All right, magnesium. So magnesium sulfate has sort of long been used as a treatment for refractory wheezing and bronchospasm related to asthma and COPD. It primarily works by relaxing smooth muscles in the bronchioles to help open them up and help patients breathe. Its most common side effect, though, is hypotension, which tends to be much more pronounced in the pediatric population, which is why it really wasn't added for pediatrics and only for adults because of the significant hypotension that children can experience after magnesium administration. It has been added as a Category B medication for respiratory distress protocol in 3.29. And it's given as 2 grams diluted in 250 mLs of normal saline, either IV or IO, and given over 20 minutes. And the reason for the length of that infusion is really to help aid with the hypotension and to prevent sort of side effects related to the magnesium. And all patients should be monitored for hypotension afterwards. They may require some fluid boluses if they experience some low blood pressure related to this. This is primarily going to be useful to folks who have long transport times, who have given a couple of neb treatments that aren't working, and may need a backup medication to help if they've got a prolonged, 45-minute, hour-long transport.
I think it's also worth noting, since when the protocol committee talked, that we recognize that since we had magnesium, that we should utilize it for all the possible opportunities, and asthma was an additional opportunity to utilize the magnesium that is already being carried.
That's right.
As long
No
as,
additional expense.
exactly. So.
And so, speaking of respiratory distress, we can talk about allergic reactions now. So this protocol was actually made based off changes, or based off some recommendations and some feedback from providers in the field who were working with this protocol every day. The protocol really had gotten sort of a little complex. It was broken down into mild, moderate, major, severe category, and really kind of got confusing with people trying to categorize people and where they fit. So we sort of changed this and just made it simple and then combined the moderate and severe into a single category, since they're largely treated the same way anyway. And so hopefully this will avoid some of the confusion. Moderate or severe reactions are really defined as rash, but also with the presence of respiratory distress, wheezing, airway compromise, and can include signs of shock in patients who have developed fulminant-like anaphylactic shock. Emphasis was really been placed on the use of IM epinephrine, the 1 to 1,000 IM epinephrine, as opposed to the IV route, really because it's A, easier to administer and quicker, and B, has really favorable sort of pharmacokinetics when it comes to absorption and how the body processes it when it's related to an allergic reaction. So just keep in mind, though, remember 1 to 1,000 really is only for IM, should never be given IV. IV epinephrine, which is 1 to 10,000, was kept as an option, though, for refractory anaphylaxis or anaphylactic reactions that aren't responding to IM epi, but it does require online medical control approval prior to usage. And that's where you're really going to see that changes in Protocol 3.04, noting that IM is really the preferred route.
Excellent.
So that applies to adult patients as well, correct, Sharon?
Correct, yeah.
Excellent.
Fantastic.
So I think this will be a segue, since we've been talking a lot about alternative routes of giving medication, whether it be intranasal or IM being a great choice. We'll kind of segue into talking about IO and some changes that we've seen. IOs have been in the protocols for a long time. It is placement of the IO needle into the intermedullary space, which allows direct access to the vasculature. It's a fabulous way to provide medications, easily deliverable. There are a number of different ways to place these. The big is displayed here, and I know a few services still use that. Most services are moving towards the drill, though, as their preferred method. Very easy to place. You just need to be very cognizant that there are different size needles, and we'll look at some pictures about making sure that you are choosing the correct size needle for this. So IOs in the proximal tibia have been approved for quite a long time, as well as sternally. They've been approved in the adult population. There's a very specific delivery device that must be used to place a sternal IO. But with the new review of the protocols, after review, it was felt that we should expand this to a third location, and that would be the proximal humerus. This is well described in the literature, it's easily accessible, and so we felt like we should also expand the protocols to do this. So placing an IO in the proximal humerus is an acceptable route as well. So these pictures just demonstrate that it's imperative that you choose the right size needle to go along with your patient, and there are 3 different needle choices: your pink, your blue, or your yellow, as long as if you're using the drill and using the right size, because you need to make it to the intermedullary space, or the fluid will just be going to the subcutaneous tissue and won't have any direct benefit. So for review, you can put an IO in the proximal tibia and now in the proximal humerus as well. We have a graphic display here of showing the location for the proximal humerus placement, and then of course in the adult there is still the sternum that can be used with an alternate device. Now Shay, I believe you were telling me about an app?
Yeah, so like many things, there's an app for that. So Arrow, which is who makes the EZ-IO, actually has an app that you can download to your smartphone from the App Store, which actually has videos and pictures on how to find placement, how to make sure you're selecting the right size needle, and actually even down to the basic operation of the EZ-IO and how to flush it and how to load it with lidocaine, everything you need to know to place these. So like with many things, there's an app for that you can get.
So that's great. I think that'd be a fabulous teaching opportunity for a lot of our pre-hospital providers. Awesome. Excellent. Thanks, Shay.
All right, so talking about hemostatic agents now, studies from the battlefield and updates to advanced trauma life support, pre-hospital trauma life support, and tactical combat casualty care have really continued to reinforce the importance of rapid and quick control of bleeding in trauma patients. And hemostatic agents have long been shown to be a safe and effective way of doing this. They're really used to control bleeding, mainly places that aren't amenable to tourniquet administration and where bleeding is not controlled well with direct pressure. So places like the axilla, the groin, sometimes the scalp and face, places where placement of a tourniquet is really going to be difficult as a method for bleeding control. Open abdominal wounds and chest wounds in the protocols can be used, hemostatic agents can be used, but it's only with hemostatic impregnated gauze. It's not the actual like powdered hemostatic agents. Newer agents, there's a lot on the market now as the science behind these continue to evolve, and they've been shown to be very effective and produce less like burning and side effects that the older ones did. And the protocol update here was really to include some of those newer agents that are on the market. Ones that were already on in the protocol are pictured here: the Silox gauze and the Quick Clot Combat gauze. The Hemocon dressing is the new one, along with Newstat, which have really been added as acceptable methods acceptable items for use in the hemostatic agents this year. Please remember, though, that each service has to be trained to use the hemostatic agent selected by their medical director. So that's an important point, that the agency really does need to do training on these. This isn't a whole, one for the state and everybody knows what to do. So make sure that if you're selecting these for your agency, you really do need to undergo training on how to use them appropriately.
Absolutely. All right, now we're going to talk about shock. Speaking of hemostatic agents, hemorrhagic shock is certainly something we treat a lot, along with other kinds. But we reviewed the shock literature, and there's a lot of data out there talking about the use of permissive hypotension during resuscitation. Previously, our goal had always been, in patients with shock, to get that blood pressure up, get it up, get it up. And so we had a goal blood pressure of 120 systolic. And based on the new literature, basically, we've changed that goal from 120 to 90 systolic. And that's the long and short of that. This applies to all kinds of shock: hemorrhagic, cardiogenic, distributive, any kind of shock. So just wanted to point that out. Speaking of shock, sometimes we do have patients who die in the field, unfortunately. And we did make a change to this protocol. Primarily, the change is going to apply to helicopter EMS, but also could affect ground agencies. What we found is that sometimes the service medical director is actually also providing online medical direction for an agency, but may not necessarily be working at the destination hospital. So in circumstances when the online medical director declares death in the field during a transport, but that online medical director is not at the destination hospital, then that destination hospital has to be notified. This is just obvious common courtesy to me. But sometimes we overlook that. And you just want to make sure that they understand what's going on with the patient when they're getting ready to receive this critically injured or ill patient. We want to make sure that they know what's going on. So we just wanted to clarify that in the protocols because it has come up a few times in the last few years. You'll see that change in several places in the protocols, but it's the same information repeated throughout. Well, now we're going to talk about cardiac arrest, and this is actually the thing that held up our protocol updates a little bit this year because we were waiting on the AHA to release their guidelines. They were updated in October 2015.
Talk about like not very long ago.
Exactly, not very long ago now. So these finally did come out, and when we looked at them, we found out that truthfully there were not a lot of changes when it comes to adult patients. If you would just advance the slide, we'll talk about exactly what those are. The biggest thing is they talked a lot about changes in chest compressions, and I think really in Alabama we had already adopted these changes in our last protocol update. So I think most of these are things that most of us are already doing. But I want to say now, if you've been asleep through this entire broadcast, I want you to wake up now and listen to this point because I think it may be the most important one we're going to make today is talking about high quality CPR because in Alabama our cardiac arrest survival rate is not good. And the things that have been shown to improve that are good chest compressions and early defibrillation. So the high-quality chest compressions are really critical. The rate for those chest compressions, 100 to 120 per minute. Not slower, not faster. That is the sweet spot. If you go too slow, you're not pumping enough blood. If you go too fast, you're not allowing the heart to fully refill with blood before you compress it again. So that really is the sweet spot. Now, a lot of people ask, how can I get that 100 to 120? There's a few ways. You can sing Row, Row, Row Your Boat. You can sing the song Staying Alive. I'm not very good at singing, so I just try to figure it out myself. A lot of people recommend using a metronome, and guess what? There are apps for that.
That's true.
So there are also some devices out there that you can find that you can clip onto your life pack or whatever monitor you're using. You can clip them onto your back valve mask. There's a lot of different things out there that you can use.
And some of the monitors have it built in as a function now. The LifePak 15 has a built-in one that you can click the button and it'll pace off your compressions for you.
So whatever monitor you're using, whatever device you choose, there's ways to get that sweet spot of 100 to 120 per minute, and that really is so important. The other thing that's really important, besides the rate, is the depth of compressions with a full chest recoil in between. So we're going for that 2 inches on adults with full chest recoil in between. And then, of course, early defibrillation, which we've talked about for years. A couple of other things that AHA mentioned in the adult cardiac arrest guidelines is they wanted to really, they recognize the problems with opiate overdose as well. They talked about considering giving naloxone to those patients in cardiac arrest because they may have gotten that way because of a respiratory arrest related to an opiate overdose. So they talked about that some. And they also, we can say goodbye to vasopressin. It's gone. Those of you who are big vasopressin believers, I'm sorry. Basically, after a literature review, the AHA said that the vasopressin really didn't pan out to be any more effective than epinephrine. And there have been a lot of difficulties with services getting vasopressin even. So, sorry vasopressin, you're out the door.
I think going back to your point about chest compressions and how important they are, I think it's worth noting that in order to do effective chest compressions at the rate of 100 to 120 to a 2-inch depth with full recoil, that's pretty exhausting, even for a lot of our pre-hospital personnel who are in incredible shape and out doing vigorous activity. They may need to switch out people to do this effectively, especially on some of these lengths of transports that they have.
Absolutely. That's a very good point because you really get exhausted quickly doing proper chest compressions. So switching out providers is important. And when you do that switch, I encourage people to practice doing those switches because you really want to minimize those interruptions in chest compressions as much as possible. So actually, if you practice it with your crew to make those switch offs go smoothly and minimize those interruptions, it's very helpful.
Excellent.
I think that's another good point is minimizing interruption. That includes for things, even procedures like intubating the patient. I mean, we really want to try and minimize those interruptions in the chest compressions as much as possible.
Yeah, placing those defibrillator pads, that's another place where time is lost. So definitely we want to minimize those interruptions.
Now, have there been some changes to the peds?
There have. A lot of the changes in PEDS really do sort of mirror some of the adult changes that came out in the new PALS guidelines. There's, much like in the adults, there's that emphasis on high-quality chest compressions, rate of 100 to 120 per minute. In little kids and babies, the depth is 1.5 inches, with 2 inches in sort of older children, sort of that elementary school age and adolescent age range. Again, making sure to allow for full chest recoil, and the emphasis on early defibrillation as well. One of the things that was also, and it continues to be emphasized for PEDS, is the use of BLS airways, which have been shown to be very effective in the ventilation of children and in resuscitation of children, especially with the difficulties of intubating some children. Children have very difficult airways. It's hard to do, especially if you don't get a lot of practice, which unfortunately a lot of folks don't. And so there is a continued really emphasis of good high-quality bag valve mask ventilation with oral airways and BLS airway maneuvers. Lidocaine is now back as an option for shock refractory VFib and pulseless VTAC in the PALS guidelines as an alternative to amiodarone, which can be painful to draw up. It's like drawing up soap bubbles. And then there's also, much like in kind of to mirror the adults, that emphasis on thinking about opiate overdoses and suspecting those, treating with Narcan if necessary, and then the deletion of vasopressin from the PALS guidelines as well. But there's also been some changes for newborn, which has actually been a lot of changes for our protocols.
Well, it is quite a few changes, but I think that they're logical changes and they make sense. The primary changes that we've seen are with, of course, assess the infant's breathing and heart rate as always, but institution of bag valve mask ventilation should be done at a rate of 30. The prior recommendation had been somewhere between 40 and 60. So they've established a rate, it's now 30, it's a set rate, and it's a lower rate than before, 30 breaths per minute, and that is if the infant is gasping, if the infant is apneic, or if the heart rate is less than 100. There's also been a change to the chest compression rate. It has been reduced to 90 per minute. Previously, and that's if the heart rate is less than 60, previously it was a rate of 120. So the logic in this is that if you're breathing at 30 times a minute and doing chest compressions at 90 per minute, the combined rate is now 120. So that's an easy way to remember that. So 30 breaths per minute, chest compressions of 90 per minute. And then if it's a particularly long transport time or if there was concern for diaphragmatic hernia, then you should consider endotracheal intubation. Of course, that is a category B and would need a call to your online provider as well. So the other change we've seen is now APGAR scoring is going to be done at 3 separate times. It had been just 2, now it's going to be at 3 times, at the time of birth, at 1 minute, and at 5 minutes. And if you want to review your APGAR scoring, there's no point in me doing it here. You can go to the protocols, and those are listed out for what does APGAR scoring.
Fortunately, they're built into most of the EMRs now, too, so you just have to click the right number on the box.
Excellent. So, very nice. So, just to review, bag valve mask ventilation change is now at 30 per minute, and the chest compression has changed down to 90 per minute. So, keep those in mind and think about that as we go forward. So, in summary, this has been a great day with the two of you to get to review some of these changes. Just in summary, some of the things we've talked about, lots of changes are going on in the pre-hospital world, and we try to stay abreast of them, and a lot of the changes we've seen were brought forward by pre-hospital providers, and so we enjoy getting that feedback from pre-hospital providers about things they'd like to see, and
Absolutely.
We'll be happy to update those. Stay current on all of the latest updates in both adult and peds to provide the best possible care, and if you ever have a question, go straight to your protocols. That's the 8th edition protocols.
Absolutely. If you have questions that are not answered in the protocol book, one of the first places you should call is your regional EMS office. Of course, I don't want to glaze over the importance of calling your service medical director. I'm sorry, I should have said that first, because that really should be your first line. But your regional EMS office is also available to help you. And then if you have some questions that they can't answer, we are available at the state EMS office to assist you in any way. Thank you very much.
Thank you.